everyone. I'm James Cape, and I'm the current president of the Intel Alumni Network, or IAN, IAN for short. IAN is a nonprofit global community of Intel alums who connect with each other to expand on the values and experiences that we shared at Intel and continue in life's adventures. Increasingly, IAN is offering webinars designed to keep not just our members current on technology trends and its impact on society, but we're increasingly offering our content, which we produce about 1 or 2 a month, to a broader audience. But for today's webinar, we are fortunate enough to have 3 true experts in the field of healthcare that will discuss the major changes, some of which were facilitated by what happened during the COVID pandemic, about how we are going to consume healthcare in the very, very near future. Also, I want to welcome the people who are not Intel alums. We have expanded the net of people that we've wanted to invite, and including friends and family, as well as Intel employees, and frankly, anybody who is interested in what the delivery of healthcare, among other things, is going to be like as we head into the next 5 to 10 years. For those of you who are not Intel alums, one thing that you should know is that Intel employees are not shy about asking challenging questions, and I encourage you to think about your most difficult questions to ask our esteemed panelists and put that into the Zoom Q&A window, which I will be monitoring and feeding to our moderator, Dave Ryan, as we move forward with this session. And now we'll turn it over to Dave. Dave is also an Intel alum, relatively recent grad, so to speak. He was involved with Intel's global healthcare and life sciences business before leaving to form Spective Vita, a strategy consulting firm focused on deep tech startups that are focused on the life sciences sector. He is also a senior advisor for the American Telemedicine Association for new initiatives such as home testing, therapeutic advances, and health equity. He is also a member of the CEO Advisory Group on eliminating health inequities and disparities. And with that, no further ado, take it away, Dave Ryan.
Hey, thanks, James, and the check's in the mail for that. I do want to thank you, though, for giving me the honor and privilege of pulling this panel together, because after a couple of decades of driving and fueling technology to try and help the struggle to remake, healthcare, which is run by a 200-year-old industry model, we're all fortunately experiencing like real change, real transformation in how the first, I think of the first digital health era changes that we're living in our own healthcare. And so now what we learned and to consider normal as we grew up, or typical healthcare and medical experiences, effectively obsolete. There's so much change that's happened. And in hindsight, while the pandemic was horrible, it had some dividends too. It forced the industry to embrace innovation, dissolve most of the barriers to innovation, and take any really plausible good idea and give it a try. Let it prove its worth in the throes of the crisis. So we wanted to pull this session together to try and unpack the changes that have happened, to understand where we really are today. And of course, what are the challenges going forward that remain to be done? We'll talk primarily about 3 big ones: the personalization, the precision of how medicine and care is delivered individually, remote care, that is taking care to wherever the patient is, wherever the clinician is, and enabling the fluidity of the delivery of care, and also whole person care. Where are we in terms of the physical care, our physical care being taken care of it in parity with our mental care, the entire person healthcare. So we have some really true industry leaders joining us. Let me take a few minutes just to introduce them to you, and then we'll get their questions and perspectives on these topics. And please start filling up the Q&A section with questions as well. So Dr. Jordan Shlain is with us. He's a practicing internist and founder of and chairman of Private Medical. That's a membership-based comprehensive family practice. He's really passionate about personalizing medical care to individuals and families, and he's founded some companies as well to help that. Health Loop is a digital platform company acquired by Get Well Network, and he's also founded and chairman of Eat Real, which is a nonprofit that helps schools improve the food that they serve. He's a self-admitted science geek. I think you love hearing from him, and he's a clinical advisor to a whole bunch of innovating groups, and is a guest lecturer at Princeton, Columbia, UC Berkeley, and Stanford. You can also catch him on his new Inside Medicine podcast, where he takes emerging topics and he finds experts to bring facts to the noise. And so welcome, Dr. Shlain.
Thank you.
We also have Dr. Joseph Kvedar. He's professor of dermatology at Harvard's Medical School, and he's a senior advisor in Mass General Hospital's Center for Innovation in Digital Healthcare. He's the immediate past chair and of the board of American Telemedicine Association, is where I got lucky enough to meet him. And he's the editor-in-chief of Nature's journal called NPJ Digital Medicine. He's also the co-chair of the AMA Digital Medicine Payment Advisory Group. And that group has worked successfully to expand reimbursement and coverage of telehealth and remote monitoring, making it a part of healthcare and the reimbursement of care. Dr. Kvedar is an author of 2 books on digital health, and that's where I first learned that he stumbled upon his own discovery of connected care and the passion for that. And it led him to become a connected care pioneer, like way before it was cool. Welcome, Dr. Kvedar. Great to have you here.
Really delighted to be here, Dave and Jordan.
And to round out the panel, Dr. Thomas Insel is a psychiatrist and neuroscientist who, for 13 years, led the National Institute for Mental Health at the NIH. So during his time there, he's the nation's psychiatrist. He influenced tens of billions of dollars of research with a shift towards neuro and genetic science that he drove. After he left to go to Verily and lead their mental health team, co-founded MindStrong Health, and served as, in California here, as a special advisor to the Governor Gavin Newsom on behavioral health in and across California. In addition to advising countless companies and foundations, in these last 2 pandemic years, he's filled up his idle time by creating 3 companies and writing a book. Humanist Care is a therapeutic online community for recovery. Vanna Health helps people with serious mental illness engage in supportive care. And the nonprofit Mindset News is a digital publication focused on mental health. His newly published book is Healing: Our Path from Mental Illness and Mental Health. And I hope we get to talk about that in just a minute. But let's get going and let's unpack these trends. And Dr. Shlain, I'd like to start with you. Let's start with personalization and precision care. What the heck is that? How's it different from other healthcare? And in your own practice, how far have you gotten with precision and personalized medicine?
Well, thank you. I feel like which one of these things doesn't belong with the other ones. I'm here with Tom and Joe, and I'm honored. Let me, before I answer that question specifically, which I do want to answer specifically, I want to zoom out one click. We talked about these trends that have happened with the pandemic, and I would start with, and I mentioned earlier, you can't change the conversation until you change the language. And I think that we have a health insurance system. We don't have a healthcare system. And we're not really being intellectually honest when we say healthcare system, because it's a broke fix system. It's not a proactive preventative system, which I think we all want. So you just said something interesting, which I remember I was talking to the head of the AMA. When we talk about the word reimbursement, like that word in and of itself, like when I go to the store to buy food or buy gas, I'm not reimbursing them. I'm actually paying them. And the fact that we use reimbursement as a concept, because like the guy that didn't get reimbursed, you can feel bad for him a little bit, but too bad, sucker. You shouldn't have given the guy the money in the first place. But the guy that didn't get paid, you feel like, hey, there's an inequity there. So like to me, like, and I'll drill into these things throughout this conversation, but I do think it's important. And for example, we say patient-centered care, and I know that's a big buzzword and healthcare uses a lot of those terms. I don't know what the patient is in the center of. The center of what we, and so there's like, I have a lot of problems with the nomenclature that's used. And I also don't think there are consumers in healthcare. I think there are utilizers. I've never seen a consumer in the ICU, just to put a finer point on it. It's so language to me is important. And then even when we go to Don Berwick, who I'm sure many of my panelists know, he came up with the concept of the triple aim. The triple aim is improving individual experience, improving health populations, and reducing costs. The last time I aimed at something, I aimed at a single thing. And so I think if we aim for good outcomes, you will get, if you just focus on outcomes and that's it, you will get a better experience, because you can't have good outcomes with a bad experience necessarily, and you'll have lower cost. So I think we've distracted ourselves a little bit from all the things we're trying to do. So let me get down to the specific question: is what is precision medicine, and how do I use it in my practice? I'll be provocative and say there's no evidence for evidence-based medicine when you're dealing with an individual. Evidence is based on populations. And if you look at the Gaussian distribution of a population, like one could be over there and one could be over there. And how do you know which person in the population you're trying to get to specifically? And the truth is evidence is a really good guide to tell us, what will work for 80% of the population, but not necessarily the 20%. So precision medicine is, how do you figure out which person, which plot on that distribution, and what is the efficacy of any diagnostic or therapeutic pretest probability and or a therapeutic opportunity. So I think it's important to understand that precision medicine and personalized medicine is trying to understand what people's risk profile is. Think about your asset management, all your assets. Like you have bonds and you have stocks, you balance your portfolio of risk. So your body is a portfolio of risk. You've got cardiovascular risk, you've got mental health risk, you've got metabolic risk, you've got environmental risk, you've got lots of risks. So how do you quantify those in a way that you can then look forward and say, these are your risk for things, and here's how we go forward and screen. But more importantly is, I could tell you what your risk profile is, but your risk tolerance is a completely different facet of the conversation. If you don't care, or if you care a lot, that's going to change how I work with you in trying to develop a strategy for your health. So specifically, and I'll just go to the newer test that's out there, and there's a bunch of really cool stuff in mental health. I can't wait to hear from Tom about this stuff. Is the cell-free DNA. So people talk about longevity and people want to live long, I guess. But the truth is what we really want to do is make it to our naturally programmed expiration date. And like, we don't want to get cut short. Like if I'm supposed to live to 88, I don't want to get cut short at 71. Like that would suck. So there's a cancer test now that's working its way through the scientific community that's been out for about a year and a half, and it measures 42 different cancer types by looking at DNA in the bloodstream and then reconstituting them with AI and ML to say, oh, this was like a fragment of a prostate cancer or a breast cancer. So I had a 38-year-old guy come into my practice a year and a half ago, and he said, hey, I want to sign up. I want you to be my doctor. I said, okay. And he was a little overweight, had diabetes, had some issues that we were going to try to tackle. And he said, my grandmother, and he was from the African-American community, and not a lot of good medical records there. So his grandmother and his mother didn't really have records, but they both died of some GI cancer in their 50s and 60s. So he was really afraid of that. He's about to have kids. So I said, well, there's this new test. It's $1,000 though, and it's not reimbursed, or it's not paid for by insurance companies yet because the data is not all there. So I did the test and it was positive for colon cancer. And I was like, okay, first of all, this guy wouldn't have gotten a colonoscopy till 45, maybe 40 because of the family history. And it lit up positive. So I said, well, that must be a false positive because those can happen. We did a Cologuard stool test. It was positive. I did a colonoscopy. It was positive for a 2-centimeter tumor in his transverse colon. And then we did a major surgery, chemo, radiation, and 2 years later, cancer-free. Okay. That guy would have been dead before his first colonoscopy. So that's precision medicine. And personalized medicine was me listening to him and even offering him that test because he really cared about it. So I don't want to take up too much time, but I think there's a lot of interesting companies coming down the pipeline offering a lot of things that can be precise and precision, but you got to have the personalization. And I saw somebody asked a question. I'm afraid I'm going to die because my doctor made a mistake or didn't communicate. And so my advice is like, you need a good quarterback, and it's really hard to be your own quarterback when you're not an expert in this realm, because it's a really complicated realm we all kind of exist in. So let me stop there and stop talking.
Hey, Jordan, can I jump in on this? Because I do think it's an important distinction between precision medicine and personalized medicine. So, and I love the fact that you care about words and language, because I think that's so important for us to keep an eye on. But those two things get confused a lot.
Yeah.
People talk about them as if they're the same. Can you just help us distinguish again? I think you started down that road, precision having something to do really with either earlier diagnosis or more precise diagnosis, but personalized seems like it has something more to do with individual preference. Is that fair to say?
Yeah, I think the personalization is it's not what's the matter with you, it's what matters to you and what's the matter with you. So you have to put them together. The house of medicine is always asked, what's the matter with you? I think the house of psychiatry and mental health is always asked, you know, what matters to you. Like I think, but rarely does an internist. I mean, I call my patients psychologists and say, hey, and like the psychologist, like I've never gotten a call from an internist before. Like what's, and I said, like the patient wants us to communicate, and they're like, well, I don't take, and they're freaked out. But then when we start talking, they realize like, I'm 70% doctor, 15% psychologist, 10% rabbi, 4% bartender, and 1% friend. That's how I kind of see myself to my members. It's because I want to, like, I don't want to be their friend, but I want to be someone they can tell everything to. And so it does get down to this, I would say, relationship and this implicit and explicit trust. Because to me, health is all about what you are, health and what you can do for yourself. Healthcare is when you can't and you need to go somewhere else. So you have to outsource your sense of agency. And that's a very scary thing to do. And so if you have somebody that can help you do that in a way that's material to like developing a strategy and how to talk to you about what tests, and there's all the fear and anxiety, then I think that's personalized medicine. Precision is really like, we can talk about pharmacogenomics for SSRIs, for example, like that's going down the road of precision medicine. I don't want to use this drug because you metabolize it differently than that one. So let's be precise about what we're going to use, so we don't have to do a trial and error of 4 or 5 different SSRIs, antidepressant, anti-anxiety drugs before we find the right one and that works the soonest. Because my goal is to get the best outcome the fastest.
Cool.
Hey, Dr.
Thank you.
Shlain, I'm going to two sort of audience questions. One, real quick, what's the name of that test you mentioned, the new test?
Oh,
And
it's Grail is the name of the company, like Holy Grail, and the
okay.
test is the Galleri test, which is the guy that discovered cell-free DNA. So,
and the other is, personalization. This sounds expensive. It doesn't sound like the kind of healthcare I get or everybody gets. Is this experience only accessible to the deep pockets, or what should we expect there? Where is it today, and what should we expect in the near future based on economic means?
real briefly, and I don't want to hog up this conference. I want to hear from Joe and Tom. What I would say is when Tesla came out with their $180,000 Roadster, it was very inaccessible, and it was kind of this weird thing. But private money funded a new revolution. And then they built a cheaper one, and everyone's copying them. And now EVs and electric vehicles are a real thing. So concierge or membership rate medicine started off being expensive, but it's now coming down to the masses in a lot of different formats. I think One Medical had a run at it, but that's slightly different. But I think it's not that expensive. Again, if you think about what you spend on everything in your life, and then you ask yourself, how much am I investing in my health? So you shouldn't look at like me or membership-based doctors as an expense. You should look at them as an investment in your health, because now you have somebody that's got your back, that understands you, and that's going to help organize your stuff. So there's a great big market for this stuff right now, from like $35 a month to $35,000 a year. And it depends on what neighborhood you live in, but I think a lot of primary care doctors, 85% of them are owned by hospitals now, and it's a money-losing business. So a lot of doctors are kind of going back out into the realm of striking out on their own and like having direct financial and relationships with patients, because then they're accountable.
All right, so Dr. Kvedar, let me bring you into this. Some of what Dr. Shlain talked about, you've got to be in the office for, but most of that relationship, no. And I think, the pandemic taught all of us what a televisit was. So how far are we really in mainstreaming telehealth into, medical practice, where we sit today, and where's it going?
Pretty far. I must say, Indeed, I reflect often on, in June of 2020, we happened to have the annual ATA meeting, and I was the chair of the board at that meeting. And we just really thought that we had figured it out, that, you know, everything was going well. And at that time, we were just, many of us were just coming out of the lockdown phase. I think what we forgot was just how much of the US healthcare economy is really built around brick and mortar care. And so when a doctor has the option of not thinking about it and inviting you back to her office, and the hospital gets a facility fee for that, and then there's the ancillary lab test and imaging that's all bundled together in the same facility. It's a very powerful economic concept. Add on to that, that during the pandemic, during the, I should say, lockdown phase, people pushed telehealth pretty much beyond its limits, because for 3 or 4 months, it was the only thing we offered. So I remember being on a panel with a colleague, a friend that I actually was an intern with, and saying, I don't think you can really do a very good lung exam. And she said, oh, no, I have the patients walk up and down a flight of stairs and I can tell if they're short of breath. So people pulled all these tricks out of the basket, and that's something to celebrate, because we took care of our patients and we did so without bringing them into the brick and mortar. But it also gave people a twisted view of what telehealth can do. And so I would come back to it and say, we still haven't found the equilibrium between those, what I call very transactional things. I want a birth control prescription. I need my kid has a sore throat. Is it strep or am I okay? The kid's got a cough. Is it croup or is it RSV? All those very transactional things where I just need an answer. Convenience in many ways trumps other things. And how many of those can actually be done in a telehealth environment? We can talk more about that. There's so many new technologies coming up that can aid the data stream that the doctor gets to make those decisions, whether it's things like in-home devices or digital biomarkers or home testing, which you're quite familiar with as well. All of those things are coming together to give us more and more data from someone who's not in front of us. But again, the doctor needs to be comfortable that the decision being made is based on the quality of data needed to make that decision. And so there's that pull, and then there's just all this other economic stuff where the hospitals are upset that we're taking care of patients. I sit here Tuesday afternoons in my own home and I do telehealth visits, and the Mass General doesn't make a thing on that. Right? I mean, so it's profound. I don't want to take away from the gains we made. You mentioned this earlier, I think. I mentioned to a patient now, when I'm in front of them, do you want to do your follow-up by telehealth? They know what I'm talking about. That's a major breakthrough. It's a household word now, but we still have a very long way to go.
So Joe, can I ask you a question on that? Which is, I was recently talking to somebody and they said that during the pandemic, I mean, maybe it was Mass General report that I saw. So maybe in your hospital, like 86% of all visits were telehealth. There were still some that were in person because they needed to be. And then fast forward to like just recently, it's back down to 16%. Plummeted. And I wonder, is that because you can't make money doing it? And I know that I know that there's all these organizations that put forth payment. I'm not going to say reimbursement. You'll never hear me say reimbursement. Payment mechanisms for telehealth. But so that's part one, is like, did it fall down, and why did it fall down so fast, and when's it going to come back? And part two is, when I started practicing in 1998, I gave people my email and my cell phone number and my pager in 1998. And to me, all of those were telehealth. They were an asynchronous mechanism, or a non-physical. So have we conflated telehealth with video visits versus text messages, emails, and phone calls in a way that, like, if we're going to pay for video visits, we should pay for emails, texts, and phone calls. Yeah. So, sorry, those are two questions.
Two questions.
Hey, can I add a third before you? Because I really need to know this.
I better start writing, because I can only remember three things at once.
Well,
sure.
I think Jordan hits on a couple of really interesting issues, and one of them that raises for me is, I've heard that on, I guess, next Monday will be the end of the national health emergency from the pandemic. So is that going to make it more difficult to get telehealth care? How does that change the rules of the game at all?
So let me try to go in reverse order, because I had not heard that the public health emergency is being lifted. That the word on the street that we all held on to for 2+ years was that we would get 60 days notice. Maybe we're getting the 60 days notice next Monday. I have not heard that.
It may be that. It's a rumor that I heard from folks in Washington, but they didn't have any
So
certainty.
that could be, and that would put us towards the end of the year, which would make sense. I would be shocked if it got lifted before the election. But
okay.
yes, because the public health emergency threw all kinds of regulations out the window. And so the way the law reads now is that there's a 151-day period after the public health emergency where Congress has asked MedPAC formally to do a report. It's a little bit like having the hen house, the fox guard in the hen house, but we can put that aside. And talk about two things that they're really afraid of, allegedly: cost and fraud. So people in government have this notion that telehealth is great, but it's going to increase utilization. By the way, that has not been proven, and that it's going to add to fraud, which to me, plenty of fraud going on in the office as well. So anyway, that's the answer to that one. And as you know, everyone I'm sure on the call knows this, but if CMS Medicare reimburses something, private payers fall in the line. If Medicare decides not to reimburse, they fall in line the other way. So it is
saying reimbursement. I'm going to call
you. That's okay. I can say it, Jordan.
Okay.
Anyway, so that's that. So as I feared, I'm losing my memory of the questions. But the go ahead with your two again quickly, Jordan.
Yeah. So the first question is telehealth visits fell from 88%.
Right. Okay. Got that one. Yeah.
And they fell down. And the other one is like, if we're actually going to pay for
asynchronous,
why wouldn't we pay for any type of communication? It's all just communication, right?
Yeah. So the first answer has to do with something I said earlier, which is we really pushed and stretched what you could do with any remote technology during those 2 or 3 months from March through June, because we were just saying, do not come out of your home. Do not come to the emergency room unless you are sick. And so in that context, we overdid it. We absolutely overdid it. Telehealth is not by any stretch a panacea. Now, the way I follow it, which for whatever it's worth, is I follow the Fair Health Telehealth claims tracker. And so just to put the numbers into a zone that I'm familiar with, in 2019, let's say summer of 2019, the total volume of telehealth claims was 0.19%. In August of 2020, it was 7%. And by March of 2021, it was about 5%. And it's been stable since. Now, we're going to talk about behavioral health, I know, but most of that's behavioral health. And so I think there's a combination of things going on to your point, which is, yes, it's just for most doctors, they don't want to think about another channel, right? We've got it figured out how to do the channel where you come to the office. My staff doesn't know how to triage you for telehealth. All these things that need to be, if you're going to do omni-channel service delivery, you need a whole bunch of stuff, and we just never did that. And then there's the economics that I already mentioned. So because of time, I won't rehash that, but it's more profitable for the hospital to bring you into the brick and mortar. It just is. Now, last thing, because we all want to hear from Tom, I know, but the notion of asynchronous versus video, yeah, we completely started to conflate telehealth with video. It became the thing, which once again, take as an evangelist, I take what I can get. So good news is people now have a foothold in that world. But yes, I mean, I think all those communications have value and therefore should be compensated, paid for. to use the right terminology. And there are ways to do that. There are reimbursement codes for all of those things. They're somewhat tortured in many cases and difficult to implement because of things like informed consent and this and that, but they exist. And I do think that one of the things that's going to happen in the next 10 years is we're going to get much more used to that notion of omni-channel delivery. Now, the big question is, will that be reimbursed by little codes here and there, or will it be value-based? And maybe we'll talk about that later as well.
So, Dr. Insel, the telehealth during the pandemic, rule relaxation and new capabilities also enabled expansion of mental health support. And like everyone, I've got experience with the impact of mental illness. And so I dove into your book. And I've got to say, it was a sobering read. I mean, it was a really comprehensive education on how complex the problems in the mental health system are. But you're optimistic about the progress at the same time. And so where are we today with mental health care and treatment parity with physical health and support systems for that? And maybe in a nutshell, why are you optimistic and why are you optimistic?
Yeah, but I'm always optimistic, so you can't go by that. I mean, Dave, I think just to continue on this strain of thought from Jordan and Joe, this is a really interesting moment for mental health in several different ways. One of which is that, I mean, if you just think about what mental health care is, largely, it doesn't really involve surgical interventions. It doesn't require blood draws. There's not a lot that requires you to be in the same room with the patient. And so as we have moved to telehealth, as you've just been hearing, and I don't mean just by that it's just video, it could be asynchronous, it could be text, synchronous text, all kinds of things. Mental health has really been transformed. Mental health care has been totally transformed. It's really interesting. And in a way that I don't think anybody could have predicted in 2019. And I don't think it's gone back.
No.
I just, examples of this is that probably the 4 or 5 largest providers of mental health care in the United States, either psychotherapy or medication, didn't exist 5 years ago. That's like a stunning sort of change of landscape here. So we're into a different world. And it's not that surprising because you can imagine how much care can be provided with much, much greater convenience and actually lower costs, and just the ways we've been hearing about. So I think that's pretty interesting. If you look at some of the companies that have grown so much and now have tens of thousands of therapists and literally hundreds of thousands of whether you call them patients or utilizers or members, it's pretty stunning that about half of them were not in treatment before. And so what this has done is really to democratize care in a pretty interesting way, meaning that you can provide the same care from the same therapist to a person who's in Boston and Botswana. It's easy. That's really straightforward. Having said that, what this revolution has done most of all is to provide increased access with convenience and with this kind of democratization. It's not clear yet that it's really improved outcomes or improved quality. Most of what people are getting is what they might have gotten in a brick and mortar environment, but with more convenience. That's progress of a sort, but I think I often say it's act 1 of a 5-act play. And act 2 really has to be around improving the quality, making sure that people are giving treatments that actually work, whether those are medical or psychological. Act 3 is probably beginning to bring in people with more serious mental illnesses, the people who are often the most neglected, often are incarcerated instead of being in the healthcare system, may become homeless. Those are all people who really could benefit from innovation. Act 4 will be really developing the infrastructure for regulation. And Act 5, I think, finally, this becomes fully integrated with other forms of healthcare. So it's a very interesting moment, but it's just the beginning of what I think will be a complete transformation. I'm optimistic that Act 1 has gone pretty well. I think we've learned a lot. I'm optimistic that beginning to bring better quality into those interactions with better measurement, more feedback, more data, more learning is really the next thing to do. And again, just one final thought about this is if you think about what goes on, whether that's a video or a text or chat interchange, there is so much data that we are leaving on the table right now that every video exchange could have, and many of these things are open source. It could have downloads of emotional expression, tremor, lots of different kinds of ways of using AI to understand the language itself, from sentiment to coherence to velocity. All of these things really matter, and they will transform ultimately the way that we not only provide care, but that we do diagnosis. To go back to Jordan's point, that will become the basis of the next generation of precision medicine. All these kinds of data that are right there, ready to harvest, that we haven't been collecting, we haven't really been learning from. So there's a lot to be done in Act Two. I'm pretty excited to see that happen.
Incredibly exciting. I have a follow-up thought, something, and I've been following this. I'm going to try to frame the question around a chronology, and I may or may not get it completely right. But there's been a lot of, I think, negative press around one or two companies. I'm sure you're aware. And I think it was in August that I was sitting down to breakfast on a Saturday morning reading my Wall Street Journal. And the headline was that this particular individual sadly started out with ADHD medicines and spun into a negativity and ended up committing suicide. But the headline was that with only a video visit, he was able to get those medicines, as if it was somehow the video visit that was to blame. We've seen in the scientific literature recently a study that showed that increasing access during the pandemic via telehealth was correlated with a lower incidence of overdose. And so it's perhaps easy to come back to that Wall Street Journal article and say, well, the people in that company were that offered that service were somehow tainted. You know, they're marketing on TikTok and so forth. But I guess the question that I want to frame, and you've somewhat touched on it, but I want to just get some more maybe in depth is, you know, it's really twofold. One is, is there any reason that we should be damning the video visit as a way to get access to your behavioral health care? And is there any way that we should be putting limitations on these for-profit entities in any way, but, you know, particularly in their marketing?
Yeah, you know, Joe, I think it raises it's what I would call a great Act One question, which is, where is this not appropriate? Like, where are the places? And there are some. It may be that in prescribing drugs that are likely to be used for illicit purposes or to be you know, basically ripped off in some way and resold. You know, maybe that's not something you want to do by video. And maybe we need to, you know, get really clear about where this works best and where it doesn't work great. That's why I say these are early days. I think we're still feeling our way. We're going to make some mistakes, no question about it. But overall, you know, to go back to Jordan's point at the beginning, you know, we live in a healthcare environment that has been built as a business for hospitals and insurance companies, right? Mostly for insurance companies. It's a business, and it's been built to serve their needs. It was never built to serve the convenience of people who are sick or their families. What's kind of interesting is that this moves us a lot closer to saying, you know what, you'll be able to get the kind of care you want with a huge number with 25,000 therapists to select from. You can find somebody who is the person you want to see, even if they aren't in your town. And guess what? It's not just from 9 to 10, 7 weeks from now that you'll get your first appointment. You can see somebody tomorrow. And so being able to give people care in the way they want it, when they want it, where they want it, I think that's progress.
I
Now,
agree.
again, we'll learn a lot in the process of moving to this new era. But it's an interesting moment, and I think we will look back and in 2030 and we'll say, why did it take us so long to figure out that it actually matters?
I also think that kind of the part two to that is that, my father was a surgeon and I grew up in the 70s and 80s and 90s with a dad who kind of grinded through the pre-HMO era to like the full HMO era. And then I was one of the first classes when I graduated my residency where there was a hospitalist concept. Like that didn't exist. I remember the first hospitalist groups were in San Francisco, a couple of them. And so I think there's another secular trend here, which is that there's a whole bunch of younger doctors that want the healthcare system to meet them where they are, in addition to a bunch of patients who want the healthcare system to meet them where they are. And it used to be the doctors were just like caged animals in the insurance and hospital bullpen, and like they really could they weren't cage free. Like they had to like adhere to the rubric of the insurance, hospital, whatever it was system. And if you went out of it, you get called into some administrator's office and say, crank up the RVUs or something. So, so I do think that there's a bunch of younger doctors now that are like not going to play that game. They're going to say, I want my life back. I want my time back. So hopefully that will accelerate a little bit of this trend, because the Gen Y, Zs, Xs, whatever they are, they're not really going to tolerate, I don't think, for too long. And you're already seeing a lot of people leaving. So that's a comment. The question I have for you, Tom, and I know we want to get to some questions, is what we haven't talked about in mental health yet, and waiting for you to drop the beat here, is on the subject of psychedelics, because it seems to me that, there are a number of telemedicine companies going back to telemedicine that are doing ketamine by telemedicine. And ketamine, I know is proven for PTSD and alcohol addiction or some form of addiction. It's got some like good evidence there from Hopkins, but like, is that safe? Like, is that, like you said, what are the inappropriate uses? And like, maybe it is appropriate. I don't know. Like, I'm being asked to weigh in on these things as a doctor, because I have a lot of people that are interested in, like, I don't want to take pharmacologic medicines. I'd like to take a plant-based medicine. So where do you land on at least ketamine? Because that's like the one that we know has some evidence behind it, and telemedicine.
Yeah, I think it's in that box of things that are better done, at least with an initial visit that's in person. It could be that if you're taking something, sometimes there are people that take ketamine once a month for months and months and months. And it may be that in later episodes, it's safe to do. But I think in general, you want to make sure that you've got somebody in front of you when you're doing the initial evaluation and the initial administration, in the same way that I would say for ADHD. Now, you guys will know, but other people won't, that there's something called the Ryan-Haight Act, which actually requires a in-person visit before the telehealth visit. That was suspended during the pandemic. And it's a very active policy question now. Should we bring that back? And for what indication should we bring it back? And I'm open to the idea that certainly for ketamine, for any scheduled ADHD medicine, and there may be a couple of other areas as well, it's probably a good idea to at least have an in-person visit with some sense of, to go back to your word, Jordan, building trust between the provider and the patient. By the way, that's not 100% certainty that you're not going to get diversion. That could still happen, but I think it's less likely to happen than if you're writing a prescription for someone in Spokane and you're living in San Francisco.
I just challenge it. Just to be the thorn in your side, because to me, I think we would all agree you want to establish a trusting relationship, but I do think that can be done over a video call. But anyway, I'll just leave it at that.
Dr. Kvedar, you could have the last word on there, because we need to start to bring the audience into the discussion.
I just wanted to throw that out there. I cited some work earlier. There was a very long New York Times Magazine piece right after that Wall Street Journal piece. And what was interesting about the New York Times, again, sad story, a woman who started off with stimulants and ended up committing suicide. Everything was done in the office. So I just, we don't want to damn video.
Thank you. I think that's a great point, Joe. I would agree.
Well, let me start bringing the audience questions in here, and we're going to need to go through them efficiently. Otherwise, we'll be here all night. So there's a few around business model innovation, and the cost. So with all this innovation and digital health and telehealth and the changes here, and the pandemic is a giant forcing function, are we going to see costs come under control, or health insurance costs moderate, or is that going to take some other giant forcing function?
Yes, it's going to take some other giant forcing function. I mean, now quickly, telehealth, we just published a paper in our journal that utilization of primary care did not go up if you added telehealth. And I think that's worth saying, but it doesn't go down either, right? That's the whole idea of us lowering cost. It's incredibly complicated. And I mentioned value-based earlier, but it's really about how we frame our payment models rather than the technology that we use.
Yeah, thanks, Joe. That's a super important point. I think it's and there's a real need for innovation on payment, by which I mean not only what we pay, but who we pay, how we pay, what we pay for. Arguably, a really important, someone mentioned Don Berwick before, and he's an important force in how we think about this. And he's written a lot about how when we talk about health, we shouldn't just be talking about healthcare, right? We know that we're spending almost $4 trillion on healthcare, but that piece only explains about 10% of the variance in health outcomes.
Mm-hmm.
Much more of the health outcome variance is explained by where you live, who you live with, how you live, what you live for, a whole bunch of other things that we don't consider part of healthcare, but they're all about health. They really are critical determinants of health. And I think the question has to be, and this is where the value-based model comes in, at what point do we start paying for the things that actually make a difference for health outcomes that aren't currently in the world of doctors and nurses and hospital beds and emergency rooms? When do we begin to think about these other major factors? And I'll just say in California, just in the last few months, with the development of what's called CalAIM, the new Medicaid formula, the new Medicaid system in California is stunning in this. It will allow a provider, a doctor, to write a prescription for food, a prescription for rent, a prescription for a clubhouse where people could get social support. All of this is really going to be changing because people have the sense that by paying for that, you get to spend less on emergency rooms and hospitals.
Yeah.
And I'll just weigh in with one thing, because I know we have a lot of questions to get, which is technology is a tool. And humans and the technology we're talking about is digital. And obviously things that are digital can be made much more efficient, taking processes and shrinking down. That's what Intel's all about, is making things more efficient and effective. Humans are analog. You cannot speed them up. You cannot make them more efficient. And we talk about the social determinants of health, like your zip code and your waist size is more important than your genetic code than anything else. And I would say that social determinants of health as a concept, to me, like strikes at the heart of like my language problem, because it's not a social problem, it's a policy problem. They should be called the policy determinants of health. And I think that the big forcing function that we're talking about has got to be some like well thought out policy that changes what you were saying, Tom, is where this money goes, how it gets there, and what we're actually looking at. But I know we have other questions.
Well, there are a few questions about older people, and there's a connection to what you were just saying. What is coming? What's emerged in terms of caring for the older population? Is a big consumer of care that gets paid for. What's emerged that can support folks as they age, help attenuate age-related deterioration? And there's a number of folks in the audience asking, hey, I'm getting old. What can I do to help myself? What would you,
I mean, this is a question for Joe because he's the wearable,
Yeah, thank you.
health guy. So
Thanks for throwing it at me. This is something I wrote about in a book. It's 5 years old now, but called The New Mobile Age. And to oversimplify it greatly, three things that we picked up predict longevity, healthy longevity, because that's important too. One of them is a sense of purpose. That may be the most important, that you actually get up every morning thinking that when you get up, you have something you must do to make a difference. And whether that's babysit the grandchildren or still have a job or any number of things, but a sense of purpose is important. The second one is physical activity. And it doesn't necessarily have to be 10,000 steps a day, but some get up, do something, lift some weights, walk around, don't just sit in a recliner all day. And the third one is social connections, having people around you that you can be socially interactive with. Isolation, and all these things have their stats, but isolation is like a 3-pack a day cigarette habit or something like that. So those are the three things that, again, it's oversimplifying, but we wrote about that.
It's
what about
great, Joe.
nutrition? What about nutrition? What about nutrition? Sorry, you can't
Yeah.
miss that one. I think that if you eat candy bars and are social all day long, like that's not, and even if you exercise, like I think what I tell people is, don't set an alarm clock to wake up. Only set an alarm clock to go to bed so you can wake up naturally. That's good for your brain. Number two is one apple is 70 calories and represents 50% of the fiber you need in your diet in a day. That 50% of the fiber feeds your microbiome, which is your gut. Your microbiome, Tom, correct me if I'm wrong, I think produces 80% of the serotonin, which is the happiness molecule in your body. So you have to pay attention to nutrition. That's my plug.
Yeah, I would just in the book I talk about the 3 Ps, which actually go pretty well with both of you. It's people, place, purpose. So people, social connection, super important. Place, including nutrition, but having a safe, secure, thriving environment to be in. And then I think the one that we miss entirely in medicine, but is so critical, is purpose.
Yeah.
As people age, they have to have a reason to stay healthy. They have to have something they care about, and without that, things don't go well.
Yeah.
And one other
So-
comment,
so
like,
I've-
you
I've
can
read
measure
it.
stuff with wearables. Older people can measure things and they can actually get real insight into what's going on with themselves. So like, let's not forget, like you can have your agency with tools that like you're not going to be your own doctor, but you'll have insight into, yourself, your health.
Yeah.
Right.
So Intel people will be familiar with multiple dispatch. I'm going to lay out 3 questions here. You can go in a row. So Dr. Insel, good resources for finding mental health professionals. Dr. Kvedar, is there any hope to unwinding the state licensure mess that causes practice to get messed up? And Dr. Shlain, can AI help with personalization and precision? So Dr. Insel.
You know what? There is not a great resource. A lot of people use psychology today to find therapists. The American Psychiatric Association has a pretty good guide to various treatments, various medications in particular. And then for digital therapeutics and digital tools, which I'm a huge fan of, there's a tool called CyberGuide, CYBER. I'm sorry, PSYBER, CyberGuide, which is a kind of, if you will, consumer reports for the digital therapeutics that are available.
I can make the time back by saying no, not really. I mean, state licensure is it's just the worst. So again, I don't want to waste more my time, but I never say there's no hope, but there's not much hope.
All right, Dr. Shlain.
Yes. So I think AI is going to be fundamentally transformative once we get it right. I think there's a lot of promise we put into it now because it's showing promise in all these other things. But again, we're dealing with humans and everyone's slightly different. So I do think there's a lot of promise with AI in the future of precision medicine, for sure.
For sure.
We have a question about alternative healing or natural healing and moving to the mainstream. And so, when the questioner says, when you're diagnosed with high cholesterol, the automatic response is Lipitor, and there seems to be no alternatives provided. So where is alternative medicine healing, natural healing, and when would we expect to see that a part of the integrated healthcare conversation, if ever?
So let me take a quick stab at that. So my grandparents lived to 100 and they both had high cholesterol untreated. So like there's a genetic component to this stuff. So you can't just look at like one cholesterol data point and then make a decision. This is like personalized and precision medicine. And the truth is Lipitor works. It's also a shortcut. If you don't want to change your diet, exercise, and start moving and do all the things you need to do, then if we're really honest and blunt, when you turn 24, the epiphyseal plate in your pinky stops growing and you officially start aging. Therefore, you're a depreciating asset from the age of 24 onward. And so the slope of that curve is something you have some control over. And if your cholesterol is high and you don't have a genetic predisposition for longevity, then if you don't do something about it, you're going to decrease the slope of the curve and you're going to hit the axes faster than you should. So it's your choice. Lipitor. So if you want to take an alternative measure, it means you have to do a lot more work. It does work. It can work, but our society wants shortcuts. So like I'm all for the other approach, but getting people to do it is really hard. Behavior change. I'm sure Tom and Joe, it's the hardest thing ever. I have to ask anybody on this call to change their habits for a week. You can't unless you have a coach. That's my
With
answer.
all the innovation, I got a question here. All the innovation, and some of this is seriously complex, and so there's like a lot of things being bartered to people. And as a non-medical professional, how does the individual separate the charlatans and the scams from the scientifically sound choices and make it a jump ball?
I get that question every day, by the way. And so let me take a quick stab and I'll turn it over to my colleagues. But, anybody who wrote a book, and not you guys excluded, but who wrote a book and who are doing podcasts and are out in the world selling something. So if you wrote a book and you're not selling, if you're selling ideas, that's one thing. If you're selling products that like they're always going to tell you the benefit, they're never going to tell you the risk. So I live in a world of safety and efficacy. If it's safe and not effective, dealer's choice. If it's not safe and you don't know if it's effective, you're gambling. It's probably a bad bet. So you have to interrogate the science of anybody that's telling you that they have something that works. And if you're not sure how to interrogate the science and the scientific, ask them what the downsides are. And if they tell you there's no downsides, they're full of it. Like, so that's the heuristic to figure that out. I'll go offline.
Yeah, this is for this audience of Intel alums, we probably don't have to worry as much. But I have to say that I had a meeting last week with the head of the FDA, and he said the number one thing they deal with is misinformation. That right now, the biggest threat for both the CDC and the FDA is just the amount of garbage that is now being sent out onto every channel you can look for.
Yep.
And so it is a reasonable question to ask, how do you know when something is in fact reputable and believable, credible? The value of having an FDA is that you have an agency that actually is all about determining safety and efficacy, by the way, not just for drugs, but for food as well. So safety and efficacy is something that they will give a gold stamp of approval to. They don't always get it right, but they usually do. They have a pretty good process. It's very slow. The problem is they don't regulate everything. They don't regulate psychotherapy. They don't regulate surgery. There's a lot of stuff they don't do. And that's where you have to get, I think, really smart about trying to understand what is the scientific evidence, peer-reviewed papers, and what is, and in finding sources like professional societies that often will provide guidelines of what is safe and what is effective. But those are absolutely the two pillars you want to look for: safety and efficacy.
Well said.
And I'll just say that I read a lot of literature. I'm sure everybody does. I post on my LinkedIn site, like things that are science-based, and I try to refute things that are not. So I try to be a bit of a, as best I can, a public service. I'm not an FDA, but I'm just a little guy down here trying to like promote good information and dispel bad information.
So Dr. Insel, so science, genomics, proteomics, new medications, how scientific has treatment of mental illness become, other than what's somewhat called sort of just observation and just behavioral. I know, can we see advances in medicine or it's called medical treatments related to mental illness? Where are we on that?
Yeah.
There's like general question about the role of genetics and deeper science in treatment and care.
Yeah, so this is a lot of why I wrote the book that I did, partly because I wanted people to know two things. One is we have good treatments, right? We may not understand the basic mechanisms of depression and mania and psychosis. It's a lot we don't understand. The brain's a little complicated, but whether it's medical, psychological, neurotech, or rehabilitative treatments, we have good stuff. It actually works, and I think it fares very well in comparison with almost any other part of medicine. People don't know that. They assume that it's still pretty much a crapshoot. And actually, the sad thing is that many of the people in practice are using stuff that is a crapshoot, that isn't that helpful. So that's why it's so important to actually, going back to the safety efficacy question, to find people who are really know what they're doing and are giving treatments that are aligned with where the scientific evidence has been. But the scientific evidence is pretty good that medications given in the right dose at the right time in the right way are pretty effective, at least relative to what you see in the rest of medicine. Dave, you ask about genetics and imaging and all these other pieces. I think if there's a shitstorm here, it's in the diagnostic side of things. We're still, it's still a mess, and we don't yet have the kind of the biomarkers, the sort of the biological tests that we have in most of medicine to be able to say this is a particular kind of depression, which we know responds to a particular kind of intervention. And that's where this whole precision medicine revolution, which is going very quickly right now, I think really will make a difference. I would say, actually, we have a meeting about this at MGH next week at Mass General. I think within the next 5 years, we'll see a revolution in the way we talk about the diagnostic categories. In the same way, in the last 10 years, we've had that in the cancer and cardiovascular fields. It's just happening here, and it's happening not so much because of genetics, which hasn't really panned out very well for the most part, but because of using AI together with data from EEG, data from wearables, data from cognitive testing, and even getting much better histories about people's social environments, knowing about histories of childhood adversity. All of those things actually turn out to be surprisingly predictive of who will respond to which treatment. Who knew? But there's no magic bullet. There's not a single biomarker. It's taking a lot of that information, putting it together in a way that I think is actually, ultimately directional and giving us much more precision.
Two questions. First, Dr. Kvedar, then Dr. Shlain. The first, Dr. Kvedar, is, so as any good panel, we've been Googled, and the pandemic health emergency ends January 11th of 2023. So the question is, isn't all telehealth going away then? And Dr. Shlain, a question about insurance companies owning and getting engaged in virtual care platforms. Is this a good thing? Is this evil? How should we look at payers getting involved in platforms for care? So Dr. Kvedar?
The short answer is no. So I alluded to this earlier, but once the PHE sunsets, there's a 151-day time frame when none of those regulations that we talked about in terms of reimbursement payment change. Congress is looking for data during that time on those two items that I spoke about. One is utilization, the other is fraud. Well, utilization as a proxy for cost. And they'll make some decisions, presumably within that 151-day period. I will say that telehealth has enormous bipartisan support. And so I'm optimistic that there will be continued payment models and a continued omni-channel healthcare delivery, but we have to sort it out.
This question harkens back to one of my favorite PhDs in the world. She's a systems theory expert from MIT, and her name was Donella Meadows. I don't know if you know of her, but she studied complex systems, and she wrote a paper called "Leverage Points in a how to intervene. Where are the leverage points in a complex system?" It's my favorite paper. I read it about once a quarter to refresh my memory on just the way that she thinks. And the truth is if insurance companies buy telehealth platforms, we have to zoom out. We have to get meta to this whole concept of is it good or it's bad, because ultimately where change happens, it's like you could say, well, the incentives, how do you make change in a complex system? And she has a 12-point like ascending scale of how do you get to the top and make real change. And I'm not going to do all of them, but I'll go from 6 to 1. Not 12. The 6 is like the structure of the information flows. How does information flow amongst a system? The 5th one is the rules of the system, such as incentives and constraints. So a lot of people think that incentives should be number 1 or 2. They're number 5. Number 4 is the power to add or change or self-organize a system. Number 3 is the goals of the system. Number 2 is the mindset of or the paradigm with which the system arises. And number 1 is the power to transcend paradigms. And so like, I think what we're talking about a little bit here is how do we get from a paradigm of broke fix, make money, to a mindset of good outcomes and start from if the paradigm is good outcomes, you can build a goals around it and a governance system around it and rules and incentives, but you have to start with what are we doing here? So yes, insurance companies are going to buy them because it's a money-making thing. But I think this is where the policy piece has to come in. And we really have to like hold people accountable. I rewrote the Hippocratic Oath, by the way, as kind of like a fun project a year ago. And it was this, like, what are the goals of healthcare? Like, why aren't insurance companies taking the Hippocratic Oath? Why aren't hospital executives taking? Why is it only doctors that take the oath to do no harm? There's something called quaternary prevention right now. It's not primary prevention. Primary prevention is seatbelts and immunizations. Secondary prevention is cholesterol medicines. Tertiary prevention is you had a heart attack, you don't have another one. Quaternary prevention was coined in 2018, and it says preventing people from getting harmed by the healthcare system. Keep people out of the healthcare system. So like we're doing harm again, and we have to like really kind of regroup and say we're here to do no harm and to do good. And how do we do that? So I don't believe that the existing insurance companies are going to do anything unless there's enough pressure upon people to make a major change. Long answer, short question, sorry.
We just have a few minutes left, and we got as many audience questions in as I could. Thank you. I want to mention we will place on the IAN site links and references and other things that were discussed. We'll get that sorted out over the next week. Final question to wrap us up here, maybe slightly zooming out, I'm not sure. Like each to answer from your perspective, if our children or their children are watching and listening to this session or asking us about what healthcare for their life is going to look like, what's going to be normal for the lifetime of the next generations, and what can they do to help make that come to fruition? Who would like to go first?
I will get it out of the way, as they say. I mean, for me, it's access to care where you are when you need it through multiple different channels that are easy for you, that are pleasant for you. We've talked about health versus healthcare, comprehensive, a system that knows you down to the N of 1, that's you. And that's what, of course, artificial intelligence will do for us. Those things are all coming. Right now, they're like jigsaw puzzle pieces that aren't fit together yet, but they're all coming. And I think they'll get there. We still have as we've talked about for the last 10 minutes have been a bit of a downer, because we're talking about macroeconomic forces in this particular country that are skewing things in the wrong direction. But I guess I'm an optimist. I think we'll get over it.
Yeah, I'll go next. I think I'm an optimist also. Like I think the future is gonna work itself out because like this is grinding. The gears are grinding, and we've just been shown how they can run smoothly in a fully different paradigm thanks to the pandemic. I guess that silver lining there. But I fundamentally think that the way this is all the kids are gonna make a difference is they're gonna have to vote. They're actually gonna have to vote in people that are speaking about a message of outcomes and health and not more drugs and treating chronic illnesses all the time. Like, yes, we need to treat them, but that can't be the model. The model needs to be prevent them. So who's talking about that, in politics and then do you believe them? But ultimately, I think we need to start, finding a crew of people that really want to make that the paradigm.
Yeah, I know we started with the idea that we were going to argue with each other, but I'm not sure that I can argue with either Joe or Jordan in this respect. I guess what I would say is that I do think as Jordan was just saying, what our kids and grandkids will appreciate is a change in the model. The fundamental model we have right now isn't really serving anyone except potentially the payers, but it's not really serving providers or patients or families. And what I've argued for in the book is a shift from, and this is really thinking about behavioral health and particularly serious mental illness, shifting from what is a pure narrow medical model, which is kind of sick care, and that is waiting until there's a crisis and then intervening, to a recovery model, or we'll say a recovery and prevention model, which is really taking a longer view, saying, how do we make sure people get people, place, and purpose? How do we make sure that they actually are able to thrive? They don't end up in that hamster wheel of the sick care system. And ultimately, how do we start moving our payments, moving our focus, moving our technology as well into preventing the next episode or preventing any episode, so that we're moving way upstream? Here's the weird thing about that is we know how to do that. It's not rocket science.
Not hard.
This is not that complicated.
Yeah.
But we have to change the model to make it happen. And we have to start paying for things that are really focused on people, place, purpose, and prevention, not on that sick care system that today is almost a $4 trillion, 19% of our GDP marketplace. It's not really working all that well. So we need to change the model.
Well, I want to thank you all three for taking time from your day to have this discussion, and more so on behalf of the entire audience. Thank you for your careers of pioneering change and transformation, and day in and day out, year in and year out, in the work that you do, because it benefits and it helps all of us. Thank you very much. I will mention that this session, IAN will have posted and available for on-demand replay. So if you're watching this, you can let other folks know if this was interesting for them to see. And thank you again, IAN, for producing this session. It was fascinating. And as the moderator, all good plans last until they are subjected to the panel. So
Thanks a lot.
This was so much better than was planned. I very much appreciate it. To everyone, stay healthy, stay safe, and you have a great evening.
Thanks, Dave.
Well, hey,
Thank you.
Dave, thank you much for the panelists, and thank you to Dave. And I'd rather quote, the famous boxer. Everyone has a plan till you get hit in the face, right? So with that, I just want to wrap up real quickly. Thank you for everyone who's participated in this, both Intel alums as well as friends, family, and hopefully some Intel employees. And we're trying to get as many people in these thought leadership sessions as possible. And we are planning in 2023 more out speakers who are not Intel alums, but have really good thought leadership topics that they can talk about, particularly thinking about the future of the semiconductor industry and some of the interesting things that are happening between the US and China right now. So stay tuned for that. As Dave mentioned, this in about a week or two, we will post this session to the Intel Alumni Network. It's intelalum.org, and you'll be able to download and review that at that time. Thank you so much. Bye to everyone.
Take care. Bye-bye.
Thank you.
Bye-bye.